Mayo Clinic presents the Always On EM podcast, hosted by Alex Finch and Venk Bellamkonda.
Everyone, welcome to Always On EM. My name is Venk Bellamkonda.
And I'm Alex Finch.
We're really excited to have a person who is new to Mayo for us, at least in the last couple of years, but really is not new to medicine. And in fact, it's just a wonderful person. Alex, I don't know how you feel, but when he walks into the resuscitation room, I just feel that the patients are going to get great care.
I was actually just saying this the other night on a night shift. Dr. Turay came to see one of our patients at Sign Out, and the whole team was so excited to see you. And the oncoming consultant just said, when Dr. Turay's here, I know it's going to be a great night where our patients get the best care. And so that's what the whole ED says when you walk through. So thank you for your service to our patients and everything you do.
And for the listeners who probably don't know who Dr. Turay is, he's an associate professor of surgery and consultant or attending physician here in the Division of Trauma, Critical Care, and General Surgery. David completed surgical residency at Loma Linda University before doing fellowship training at Massachusetts General Hospital. I think somewhere in there you got 2 PhDs as well?
I did get a PhD. Just one.
Just the one PhD? Okay.
Just the one PhD, exactly. He's exceeding me by a huge margin. He's held many titles in his career, including Division Chief of Trauma and Acute Care Surgery at Loma Linda University, as well as Medical Director of the Surgical ICU there. Currently, he's Chair of Healthcare Quality for Mayo's Department of Surgery. He's received several recognitions for his teaching, including Clinical Teacher of the Year Award at Loma Linda. And in his short time here at Mayo Clinic, he's already received one of the prestigious Teacher of the Year Awards from the Mayo Residents and Fellows Association. He's mentored many before and mentoring several stars in surgical specialties and other specialties here at Mayo Clinic and other institutions. And as you may have guessed, from someone as educated and accomplished as Dr. Turay has been, he has nearly 50 peer-reviewed publications to his credit. But more than any of these achievements, as we've mentioned, he's just an incredible person all day, all night. He's always a kind person to see in our patient rooms. And that's the highest honor, I think, that we can bestow upon him. And so thank you so much for joining us. We're really excited to have you on the show, David.
Well, thank you, gentlemen. Thank you for the kind words. And, hearing that, I say to myself, boy, I wish my grandmother was here to listen to all the, good things you guys are talking about. But it is indeed an honor and a privilege to obviously belong to this very prestigious institution. And it's also been a mutual joy to have familiar faces like yours when I come to the ER, knowing that we all have the same objective, and that is we want to help people, and we want to do it in a way that is kind, that is, dignified, that is, compassionate, and that not only will people get care from us, but that they will feel like they were receiving care from real good friends and not just walking through and get an experience or get an operation, but knowing that there were people that truly cared for their overall health.
I think in that small introductory speech there, every emergency physician listening to this understands what we were talking about in our introduction.
Real good friends.
Yep. That's why you're an incredible physician.
Oh, thank you. Thank you very much.
Well, planning for this, we asked you what you wanted to talk about, and I was really excited we get to talk about something that is core to both our specialties, appendicitis. And I'd be curious, how does this rank on the topics that you get to treat and care for every day? Does this get you excited at all, or is this really old hat?
No, this actually gets me excited. And it is very common. And there is hardly a day that goes by that you're on call within this hospital and even outside of this hospital that you are not entertaining that diagnosis at the least. And here within Mayo, we operate on anywhere from 300 to 350 patients a year with acute appendicitis. And in the last 4 years that I've been here, we quickly looked at our database, and there were almost 1,100 patients just since September of 2020. So it's a fairly common discussion. Even more common is the possibility of the diagnosis. That's where we usually have these engagements, and right lower quadrant pain, when that phrase gets thrown around, the next question in your mind is, am I dealing with someone with appendicitis? Because we all know what the implications are if we miss the diagnosis. The other thing so not only it's exciting to me because I get to live this every day, but I think what is exciting to me is you will think after probably close to 120, 130 years since appendectomy was kind of popularized as a treatment for this condition, you would think by now, it's a long time. We know what to do with this. We got it down, but I am really excited about how just the twists and turns this disease is taken in terms of how we approach it, how we manage it, and also fascinated by the fact that there's still actually a lot of questions that we don't really know the right answers to. I mean, 120 years is a long time to be thinking and studying the same problem, and yet there still remains a lot of things that I don't know and that are intriguing, and hence, obviously, my interest in studying it further, talking to others that are studying the same thing, and, collaborating with groups around the country that share the same interest. So it feels old, but yet there are lots of things that we don't know about, and I think that, to me, that's the exciting part.
I think that's something that I found over and over in my journey into becoming an attending physician is things that I thought I really understood. Every day I'm continuing to learn more about and have even more questions about. I recently had an experience where I was calling a patient back to the emergency department. Actually, we get some overreads sometimes, and the overread showed appendicitis. And she was incredibly kind and positive, and she said, before I get there, I want to know more about this diagnosis. And I've heard this term a lot, but I don't understand how it happens. And so maybe for our learners, if you were going to break down for your residents and med students on the surgical service, how would you best encapsulate the pathophysiology of this? As this patient asked me exactly what happened, and I said, well, there's many schools of thought.
The typical of what you get through medical school and even beyond is there is an obstruction at neck or the ostium to the appendix. Secretions within the appendix get trapped. The appendix is then dilated and distended. That creates tension within the walls of the appendix, decreasing venous return, and that in turn generates more edema of the wall of the appendix. And so you feed into this vicious cycle where you have tension through the walls of the appendix by virtue of obstruction, typically from an appendicular. That's the general discussion. And the appendix, poor venous return from the walls of the appendix, causing more edema. And then if you don't intervene, that cycle just repeats itself until you look at perforation. As I looked further into this, a few interesting things popped up. And that is, early 1980s, 1983 to be precise, and in the Scandinavian Journal of Surgery, ACTA, and I'm probably going to pronounce this wrong. I don't speak Swedish or Norwegian, but ACTA Chirurgica Scandinavica. And in 1983, a pathologist and his associates wanted to answer a very simple question. Well, if this pathophysiology is true, then if I came to the operating room and right before the surgeon removes the appendix, I insert a pressure catheter within the appendiceal lumen, I am going to get a high pressure reading. I mean, that's kind of what we get out of medical school. To his surprise, out of 33 patients that he studied, now small study, granted, 19 had normal pressures within the lumen of the appendix. So this is kind of throwing this question back out, what really happens. His conclusion was something first generates the inflammation, and the inflammation then leads to perhaps downstream an increased pressure. In other words, it is not first obstruction, then increased pressure, then inflammation, but could be the other way around. The other part of it that also is intriguing is, the way this was obviously couched to us is, and this is what we say to medical students to just keep things very simple, is you get that obstruction, increased intraluminal pressure, inflammation, and if you don't intervene, it will spiral down to a perforation. Well, here's one, fact that is still very intriguing to me. You will think, appendectomy as a procedure was popularized in the late 1800s. with all that effort put in and our zeal and desire to just, you have an appendix that's inflamed, get it out, you would think decades of doing appendectomy preemptively to prevent perforation would have lessened the rate of perforation. The reality is, in nearly a century, the rate of perforation has pretty much stayed stagnant. So it begs the question, what is this disease? And is it possible that there are different spectrums of appendicitis? There are, just like Crohn's, you have real bad Crohn's. You got bleeding, diarrhea, abdominal pain, you lose weight, and if you don't put them right away and stabilize them on, modulatory medications, steroids, etc., they will develop severe complications. And then you have Crohn's where, mild symptoms. They live with it for a very long time. They do well, sometimes with just basic lifestyle modifications without really severe disease. Maybe that's what appendicitis also is. Not really sure, and that really gets me very excited because, again, I think it creates that opportunity to learn further and know more. And so it's one of those diagnoses that, you get through the first few days of surgery lecture in medical school, like, oh, I know this, I get this down. And now, decades later, I'm still thinking, I'm not really sure I know exactly what this is. So that is exciting, yeah.
That's really incredible. And to be totally honest, in speaking, when I called that patient back, they shared, I've had odd pain in this area for many years, and it's been on and off, and I've had GI workups. And I've always wondered, could I have something chronic? But appendicitis is an acute thing. And this question was imposed on me. Is this an acute process? Is it a spectrum of disease? And what I said was, the general surgeon will be able to answer all of these questions.
Well, maybe piggybacking on that, you mentioned the appendicolith as being one and maybe the mainstream potential thought. But that makes me think there are others that are on your differential as potential causes or nidus for this. Are you thinking tumor or polyps? What else outside of appendicoliths can trigger this cascade?
That is a very good question. The general thought, obviously, is appendicolith is not the only. In fact, appendicolith is associated with appendicitis in less than half of the cases. The others, we don't really have a very clear understanding. We think early on in life, it is likely that things, because, Peyer's patches are very robust in immune follicles around the appendix, within the meso and within even just the wall of the appendix is much more robust in early infancy. So perhaps maybe hyperplasia or reactive growth in lymphoid tissue around the appendix may be the predisposing factor in appendicitis in children. Certainly tumors can be implicated in appendicitis. The general thought has been about 1% of all appendiceal specimens that we remove at surgery will contain some form of tumor. The two most common obviously being adenocarcinoma or carcinoid tumors. That incidence of roughly 1% has actually been growing over the last couple of decades to a point now where it's driving us back to reconsider what we do with non-operative management. And I know probably we will get there at some point in our discussion. So a malignancy certainly could be implicated. Whether it is the inciting factor or not, that still remains to be really, really proven, but certainly at least 1%, perhaps more, slightly more than 1% of all appendiceal specimens will contain some form of neoplasia, some being malignant. So lymphoid hyperplasia or growth can probably predispose to that. As I mentioned earlier, there's a lot of opportunity to learn this and understand it better. But appendicolith is only implicated in slightly less than half of all cases of appendicitis, leaving us opportunity to question other pathophysiologists that may predispose to that.
One other question I wonder is, how does the pathophysiology evolving within the patient translate to periumbilical pain that migrates down into the right lower quadrant?
That is a great question, and this is one that I often share with residents and medical students. The appendix, obviously, is midgut structure. And when visceral pain begins, it is always going to be referred to where embryologically Yeah.
We're talking about a period of great struggle in my life.
When we had Henry on the show, the same kind of thing.
I hope I'm not triggering.
No, this is fantastic.
Here.
We've already heard Pyre's patches.
Yeah.
So
those are the phases of medical school that we all will wish we could just put behind us. And let's just do the fun stuff.
Yeah.
And that is.
No, I'm excited. I'm learning.
But yes, embryology is intimately tied to how visceral pain is manifested. When we have surgical pathologies, or any pathology for that matter, that will evoke visceral pain, that pain is always going to be referred initially to the embryologic origin or anatomic section of where that organ originated. For example, foregut structures, distal esophagus, stomach, pancreas, and gallbladder. The pain is going to be in the epigastrium, upper abdomen. Midgut structures tend to be referred in the mid-abdomen or the mesogastrium, and that will include distal duodenum, the small bowel, obviously, the appendix, which is a midgut structure, etc. When the pain is beginning, it will be referred there. And obviously hindgut structures, left colon, etc., diverticulitis, that pain is in the lower abdomen, kind of the hypogastrium, if I may use that word. So appendicitis starts out as a vague pain in the periumbilical region because the appendix originates from the midgut. As the inflammation becomes more established, it then begins irritating the parietal peritoneum. And now you start having pain right locally where it lives. When it initially begins, it's going to refer it to where embryologically it started from. But as the inflammation becomes more established, then that inflammation, that irritation gets sort of transmitted to that local parietal peritoneal layer, and that's why it becomes localized in the right lower quadrant. That periumbilical pain that then subsequently localizes in the right lower quadrant has been a fairly steady and reliable story that, if we can elicit that from the patient, really tries to narrow down diagnosis and does our work for us. In fact, some have used it. There are scoring systems in appendicitis, putting together a constellation of symptoms and objective measures, labs, etc. One that comes to mind is the Alvarado score, which is a 10-point score to try to facilitate this diagnosis, especially for junior trainees that are starting out and partners that may not have seen this diagnosis very much. We all like MedCalc, and you put this check, put this check, put this check, and the number goes up this way. Then this is what you need to think about. But periumbilical pain, relocated in the right lower quadrant, triggers a 2 out of the 10 possible point from an Alvarado score, giving you an understanding that it is actually a very reliable history if we can elicit that from the patient.
We often talk about the pain being in the right lower quadrant, but are there situations where the appendix is somewhere other than we expect it to be? And sometimes I'm also thinking about my patients who are pregnant and things like that.
Of course. Not only is pregnancy one of those curveballs where obviously as the uterus grows, the appendix is displaced and it takes a much more cephalad position. But there are still within us patients with malrotation where the appendix can end up anywhere in the right abdomen or the left abdomen for that matter. I've had to take appendixes out from the left side of the abdomen. But the one to me that sometimes has tricked me and given me a lot more challenge is retrocecal appendix, where the appendix is purely retroperitoneal. Those patients can present with very little right lower quadrant type symptoms. The pain is very vague, and the exam is very difficult to nail down because the appendix is tucked in a retroperitoneal fashion behind the colon. And interesting that you should bring that out because in my experience of doing this, sometimes those patients may not even have the other, markers, for example, white count or highly elevated CRP for, communities that depend on that to make their diagnosis. So yes, I have seen, be prepared to find pain somewhere else. The frequency of that could, range from 5% or even more in certain situations, where the appendix can, be in other locations other than right lower quadrant. But great question.
Is a retrocecal position something that can be acquired over time, or is that something related to anatomic differences from birth?
Great question. The latter is often true, but in patients who've undergone GI surgery of some kind, it is not uncommon for us. The appendix will be somewhere else, where last surgeon that was there can alter the anatomy to a point where it becomes retrocecal, kind of in an acquired fashion. But the vast majority, this is anatomically present at birth.
What you're saying is somebody already beat the video game on middle settings and they've moved it to expert for the next person.
I think that's a very good way.
Okay. I want to talk about something that all emergency physicians love, imaging. So
I thought you were going to say white count.
yeah, white count, exactly. So I have a story that either sounds classic or doesn't. Some proportion of these patients are going to get some imaging. And I think the options that I have are ultrasound, CT, and MRI. And I just wanted to get your general thoughts. Which of these can you hang your hat on? Which do you have persistent concern? And where do you go when you're upstairs and you get my call? There's kind of an equivocal finding on one of these images. How do you feel about them?
That's a very great question. And the fourth alternative there will be no imaging whatsoever. That's a very bold one.
In emergency medicine textbooks, from a lot of the texts we read now were coming out 20 years ago and things like that, and we're always reading material that was generated previously, but there was always this concept that the story's good, they're just going to go to the OR. But I wouldn't want to necessarily take someone to the OR with no information, and so that, I don't know.
Absolutely. I'll start with the last one that I mentioned, and that is no imaging whatsoever. Could there be a role to still make the diagnosis without any imaging at all? I think there is. And which patient fits that criteria? If it's a male, the story is very typical. 24, 48 hours of symptoms. Started gradually, vague, maybe became more pronounced in the periumbilical region. And of symptomatology, the one that has been very consistent is anorexia. Most publications will put out that about 90% of patients with appendicitis will have some degree of anorexia. And so if they're hungry, you have to really rethink your diagnosis, or at least be cautious about it. And the pain subsequently localizes in the right lower quadrant. And then you get the other markers, white count is high, CRP is high, etc. And you can elicit classic McBurney point tenderness in the right lower quadrant. In a male, I think if you pick up the phone and call one of us and lay it out that way, I think most of us will say, let us move forward. Imaging is probably not going to change very much. And the reality is, even if the imaging came back kind of, usually they will read some stranding, but not typical, I think most of us will say that appendix probably needs to come out regardless. So I think in a classical story, in a male with a couple other objective findings corroborating that, you can actually skip imaging. Now, when it comes to imaging, I think you have to ask yourself your question, what is the easiest for me to get? Hard these days to dissociate ourselves from cost of things, but easiest, reliable, reproducible, cost-effective, and quicker. In busy centers, here we're awash with resources. And in some hospitals, it is not easy to get a CAT scan because there are so many competing diagnoses for very limited resources. I think then you have to be very creative. If you have an ED colleague who is very versed in ultrasonography and you're trying to do this at 2 a.m, they have to call the tech from home, to come in and get the CT primed, or they have strokes and other emergencies waiting for that same resource. I say get an ultrasound and move forward. So I think you have to consider what your local resources are. Obviously, you and I practice in a place where we're blessed with lots of resources, and I think there's probably room to adapt on that. But in Europe, a lot of the diagnosis for appendicitis is made with ultrasonography. And just like anything else, the more of it you do, the more comfortable you get with it. You get a non-compressible tubular structure in the right lower quadrant for a story that kind of fits like this, and the dimensions meet the profile. I think most of us will accept it as good enough, and we're going to proceed with surgery, even with ultrasonography. Having said that, CT scan has a high sensitivity. MR becomes, and so CT, perhaps call it gold standard, highest sensitivity, is a study that hopefully settles all that questioning. The patients that we start thinking about MR and are patients who exposure to radiation could mean something vis-a-vis the pregnant patient. I think in those, it's considering MR as your go-to test to really put the diagnosis to rest, I think is very useful.
And I think some pediatric EDs and pediatric hospitals will also go from ultrasound to MR. At least they used to when I was exploring that. And this is an area that we've done some looking at Mayo's ultrasound ability to diagnose appendicitis. And just to put it out there, I think everyone should get familiar with their own center, because we have such great access to CT that we've seen that year over year use of ultrasound for this is going down. And that means our techs are getting less and less experience, to your point, David, about knowing how accurate they will be. But back in 2010 and 11, we began collecting some data about ultrasound accuracy here in radiology at Mayo in Rochester, and we published in 2014. And at that time, ultrasound were visualizing the appendix accurately about 30% of the times it was ordered. So 70% of the time they didn't have enough data to answer one way or the other. And then, but when they did see it, they were 100% accurate when we looked at path reports and downstream follow-up. So anyway, I'll put a link to that article in the show notes. And then we also talk about in there that when people are reading studies on ultrasound for appendix, you have to wonder, what do they do with inconclusive and non-visualized appendix? How do they include or exclude that from the calculation? And so when we excluded incompletely visualized appendices from our 2x2 table, we got 100% sensitivity, 100% specificity. But considering that 70% were inadequately visualized, when we add those in to our data, we found that the sensitivity went down to 70% and the specificity was only 25% if you use like an intention to diagnose method. So anybody you order the ultrasound for, you include them one way or the other. So anyway, just put that out there.
Right. And again, my thoughts on this is I think we ought, even though it's, easier for us to obtain a CT scan and certainly will remove will settle some of the doubts that we may have about the diagnosis. I think to your point, it is important for us to maintain our skills on using ultrasound for this diagnosis. If for nothing else, I think it's a good tool. You guys are involved in training emergency physicians for different scenarios. Some are going to go to rural areas. Some are going to go to, other parts of the world where this technology is not very much available. I think if for nothing else, for training purposes and familiarity with it, I think we shouldn't completely just do away with ultrasonography, even though there are some challenges that come with it. But like anything else, I think you do more of it, you get more comfortable, and I think it keeps the conversation alive.
So I see a patient, they have a story of some mild right lower quadrant pain. I get the CT, it's negative, or I get the ultrasound, it's negative. The MRI was already spun up, so we just rolled them through. Are there modalities that you think are less sensitive and they're going to get sent home and we're more worried about a misdiagnosis?
You made a comment earlier about recurring pain in the right lower quadrant area. And I'm probably going to date myself here. I was a medical student in the mid to late 90s, and the textbooks then, and to be more precise, there was a current surgical therapy. The diagnosis of chronic appendicitis was included in all the textbooks. And eventually that kind of got debated, and now, if you open modern versions of some of those old textbooks, you will not see chronic appendicitis as a diagnosis anymore. Here's where it gets very interesting for me. You get that patient where you get a CAT scan. CAT scan leaves you wondering, you don't really see the classical things that you expect to see in a CAT scan. Increase in the luminal diameter of the appendix, appendiceal stranding, fluid around the appendix, all the things that will make you think, I've got a hot diagnosis here and I got to move forward. White count stone cold normal. The exam is a little bit equivocal, or sometimes, depending on who the examiner is, it varies. Yeah, the resident comes and nothing, I see nothing. And then you come and you just put your finger on it and the person jumps. You get this variable exam and you're thinking, all right, now I'm in a hot pickle, so I've got nothing to go by. I've got a very confusing exam, and the story is really very, well, yeah, it kind of happened 6 months ago again, and then the year before, and now you're in a really tough spot. Just so that the hearers know where I sit with this, I believe that there could be a possibility that chronic appendicitis may really exist. Again, I'm cautiously putting this out there because I know this is controversial at the least within the surgical world because, if you, going back to the pathophysiology we discussed, if you have this vicious cycle, it is going to end up in perforation no matter what you think. As I told you guys, my doubts about that whole idea is, well, how come we have not seen perforations go from, about 30% nationwide, and that hasn't changed in at least 50 years? That a third of appendices are going to be perforated. Well, it could be one of several things. One is we may just not be getting to these guys as quick as we think we ought to be getting to them. But the alternative diagnosis could be is not all appendicitis will go to perforation. And so there's a lot to understand there. But coming back to the question at hand, what do you do with a patient who symptoms are at best very confusing? The exam is equivocal. It's different depending on the examiner that's examining the patient. Patient gets better. Even more interesting, they don't have all the other classic symptoms, anorexic, etc. What you're left with in that scenario, frankly, is either saying nothing to see, go home. If it gets worse, come back. That's perhaps the most aggressive, I should say, of the options, and I'm using that word aggressive very cautiously. But what most of us within this group and previous centers I've been at, the more conservative way to approach that will be admit them to the hospital, do serial exams, and then there was another diagnostic tool that we didn't talk about, and that is diagnostic laparoscopy. I didn't throw that in.
I've tried to order that in the ED, and
it doesn't come in the order set.
It's under common orders.
It's not going to be found in most order sets. It's a special order. So the reason I didn't mention it earlier in diagnostic modalities is if you put a camera to confirm whether you have appendicitis or not, if I poll 10 surgeons, I'm almost certain that perhaps 9 out of 10 will say that appendix is not going to spend another minute in that belly. and so that really defeats the purpose of quote-unquote diagnostic laparoscopy. And I think the thought process obviously is because this is a surgery, or appendectomy itself is a surgery that has such low morbidity and complications, et cetera, most surgeons are willing to just be done with us. We don't have to talk about this again. And if they present with right lower quadrant pain next time, then we know it's something else. But in very difficult scenarios, I think you have the option of serial exams. And if, you allow the patient 24 hours within the hospital to declare themselves. And if they progress, obviously the answer is very easy. You go to surgery. If they do not progress but still remain in the quandary and do not resolve their symptoms completely, I think most of us will say the next logical step is a diagnostic laparoscopy. So I know this is a long answer, but it gives you a sense as to the thought process beyond the ED when these patients come in. I think the scenarios where we'll say to them, go home and call me, I think one has to be very clear. It has to be in a case where you have a very low level of suspicion that this will evolve over time. Otherwise, I think the safest thing will be to keep the patient in the hospital, observe them, give them a period of time at least to declare themselves, and most of us will say at least 24 hours, and then make that decision.
For your residents seeing a patient, are there any things that you feel have to be obtained in the history and physical to adequately address this? And one of my attendings when I was a resident, this was anyone under the age of 18 for males needs a testicular exam because they had been fooled by a diagnosis in the past. And I've picked up these types of tricks. And one that you mentioned was, I've always heard of hamburger sign and thinking, is there anorexia or not? I had no idea that it was such a key thing in the history. Are there other things that in the history and physical you really expect that your residents will have obtained?
That's a great question. Thank you. I think in addition to the symptomatology that we've talked about, periumbilical pain, insidious onset that then relocalized in the right lower quadrant, and then, and then becomes more intense, and then you can elicit it on exam with focalized peritonitis. The key things often that I will encourage residents to do, try the best you can to tease out other differentials just so we could answer those questions and put them to rest. I think in a female, it is absolutely necessary to get a gynecologic history, all right? Menstrual abnormalities. Where are they in the process of, do they have any possibility of being pregnant? And those are things that unfortunately often get left out. And in both males and females, I think, get at least a gist of urological disorders. Is there hematuria? Is there pain with voiding? Because those are the things that can sometimes throw us in a confusing loop. So, yes, elicit or solicit information regarding to the diagnosis of appendicitis, but also get history pertinent to other differentials that are included in this. And in females, there's a long list, and it's typically tubervariant pathology, uterine abnormalities, etc., and also rule out hernias, torsion, stones, ureteral stones, because those are all part of your differential. So not only get the right history, but also get history related to what are the possibilities this could be. And I'm a big proponent, Alex, of examine the patient. It is very key. I know in this era of technology, we want to just get to the destination right away, but examine the patient.
The patient with the imaging back in the waiting room that has a diagnosis, and we call, and somebody says, "What's the exam?" And we say, "We look forward to the exam together." Yeah, no, just kidding. But
unfortunate reality these days sometimes.
Absolutely.
Follow-up question on your point about the exam. I'd love to, if you could take us and our listeners to the bedside with you. The resident has given you a great case for appendicitis. There's some imaging findings that suggest it could be appendicitis. What exam are you doing to confirm that presence? And do you use any of the signs like obturator sign, Rosving's, etc.?
Yes. So, great question. Obviously, expose the abdomen. I usually start by asking the patient to take one finger and point for me where the pain is the most intense. The patient points it, and I start in the complete opposite direction of where the patient pointed it to me. And slowly, I'll actually start by just percussing and see if I'm getting any sort of discomfort where the pain, the point of maximum tenderness is. And so start from where the patient has less pain, and then work your way by just gently palpating first, very soft, mild, superficial palpations, and then begin doing deep palpation. I usually, to keep it consistent, I go, if for appendicitis, I go in an anti-clockwise direction start from the patient says right lower quadrant is what hurts. I start in the left lower quadrant, and I go anti-clockwise and feel all the way to the right lower quadrant.
Patients lying flat with knees bent or knees flat?
So a patient who truly have appendicitis may struggle straightening out their legs completely, especially if the organ is intra-abdominal, because doing that brings the tip of the appendix in direct contact with the parietal peritoneum. That's where your clue first starts. But to answer your question, the best way to examine the abdomen is having a pillow under the patient's knees to relax the musculature so you can actually push on it. And as I said, you find out in patients with true appendicitis with an intra-abdominal organ, may not be able to stretch out their knees completely. And that's a clue in and of itself. And of course, you and I know where McBurney's point is. If you draw a line, imaginary line, from umbilicus to the anterior superior iliac spine and divide it into thirds, the junction between the medial 2/3 and the lateral third is the typically described McBurney's point. Obviously, not all appendix is going to be in that area, in that specific location, but that's the general visibility of where you expect to find the point of maximum tenderness, if I may use that word. So, knees flexed, and I start away from where the area of intense pain is, and then I work in an anti-clockwise fashion toward the area in question, starting first with just superficial palpation and then deep palpation. As far as how, do I add on the others, Rosving's signs, which obturator sign, psoas sign, I think it would all depend on what I conclude after the abdominal exam, whether I need to add these to just corroborate it. Or some days, I want to do it just so I can demonstrate to my younger colleagues that are watching me to say, have this as a tool, and by the way, this is how you do a true SOA sign, this is how you do an operative sign, if for nothing else, so that they can implement that into their future careers if they were to face a scenario where the exam is really not that conclusive and you have to add these other things, these other exams as kind of a complement to complement your initial abdominal exam.
We've covered history and physical, we've picked our imaging, and now we need to decide on a treatment. Dr. Turay, this is an area that I'm excited to learn from a surgeon. I've read a little bit about antibiotics sometimes, going to surgery. What therapies do you view we use here at Mayo, and who's the right candidate for these therapies?
I'm going to lay out the treatment algorithm as it currently stands, and this is endorsed by multiple surgical organizations, including the American College of Surgeons. If you have a confirmed diagnosis of appendicitis, the next question is it complicated or uncomplicated appendicitis? Uncomplicated appendicitis means you just have an inflammation in the appendiceal organ itself. Complicated appendicitis means you are facing somebody with a perforation with an abscess or phlegmon, which is general for just a big inflammatory mass. Typically, it's the omentum that's inflamed and kind of surrounding and hugging the organ. The current treatment thought process is if you have simple appendicitis or uncomplicated appendicitis, the answer is surgery. You get appendectomy. And in 2024, you will get a laparoscopic appendectomy. Not even sure how many of my trainees have done an open appendectomy. The last open appendectomy I did personally is I've done open appendectomies when I'm doing other things and I incidentally find the appendix to be abnormal, I'll take it out. But deliberately doing an open appendectomy, I think the last one I did was probably over 10 years ago. But I had a plenty exposure during my training years. So laparoscopic appendectomy, I think, is probably here to stay. And in fact, now the envelope is to push it even a little further and use robotic appendectomy, which is something that I am interested in because I'm learning the robot as I speak to you right now and beginning to do some robotic cases. And appendectomy is one of those on my list of cases to be done robotically. Then the other category is complicated appendicitis. Well, what if they have a phlegmon or they have an abscess? The general thought right now is treat those patients with antibiotics and delay their appendectomy till they've resolved the abscess or the phlegmon. Obviously, abscesses that are starting to reach 3 to 4 centimeters, the recommendation is to percutaneously drain those with concert with interventional radiology colleagues, essentially cool the inflammation down, and then bring them back 2 months later and do an interval appendectomy. We're beginning to challenge that notion where, as I speak to you without saying too much on this, and hope we could put our thoughts into the next publication, will be, could there be patients with even complicated appendicitis, meaning phlegmon or abscess, that you should just do surgery straight on? That's a question that has lingered on my mind for a while, and we're beginning to see some trends within our practice. I have operated on patients with abscesses, and they have done well. And just for full circle conversation, the reason why the algorithm is set up the way I had it is because for the last 2 decades or so, the concern has been if you're operating in the setting of a phlegmon or an abscess, your rate for needing to do a much bigger operation or complications, which will mean leak at the appendiceal stump, etc., is much higher. And that's why most organizations and most surgeons know this to be the current standard of practice. As I'm mentioning, here at Mayo, we're beginning to push that envelope a little bit and say there could be a certain subset of patients with complicated appendicitis that probably just will benefit from straightforward surgery. So surgery remains the cornerstone of treatment. Having said that, I am very much aware of all the literature that has been poured into looking at, do we even really need to take the appendix out? Can we just do antibiotics and resolve it like that? There has been about half a dozen randomized controlled trials looking at antibiotics as the sole treatment for appendicitis. Big study from France, actually started first in Scandinavia. And Styrud and colleagues and Eriksson and colleagues, and more recently, 2015, Salminen from Finland. All these folks were pushing the envelope and saying, could we just give them antibiotics and send them home if they otherwise don't have abscesses and they don't have any other complicated factors and we don't find a perforation? Can we just treat them with antibiotics? It's a topic in and of itself, and I could spend the next hour just talking about my gleaning of the readings. But here's where that discussion stands. The last big randomized control trial on this was the CODA trial, CODA, and that was in 2020. Here are things that we ought to know. If your patient brings this up and you're having a conversation with them, about roughly a third of the patients who were randomized to antibiotics alone in all those studies, and I'm speaking kind of just broadly and collectively in the interest of time, ended up needing an appendectomy often within 90 days. And so patients need to know that if you are going to choose antibiotics, it is an option, but know that a third will recur, and probably more than a third will recur. But at least within the first 2-3 months, 1/3 will recur. Here's the salvo on that. In most of those studies, the recurrence was treated safely with an appendectomy. In other words, if you err on the side of giving them antibiotics and should they recur, you will expect the surgery to be more difficult because it's a recurrent inflammation. And my take on that was, from reading those papers, was the surgery did not seem to be extraordinarily more difficult. So in one way, you could say that is reassuring. But I have to hasten and mention that the gold standard for treating this disease is surgery. Having said that, I applaud the efforts of trying to push the envelope and asking the question about, can antibiotics help? I think my take on that right now, it is a temporizing measure. There is a well-known study, very small, 9 patients from the Navy, where seamen that were, down thousands of feet got appendicitis, and, you can't get a surgeon down into the submarine. And I've never, served in the Army, but I have a general notion of how difficult it is to catch up, with a submarine. And so those guys were safely managed with antibiotics until they could bring them to shore and eventually treated. Again, antibiotics could be a temporizing measure. We do have patients who cannot get surgery at that time, either because they are actively on chemotherapy, they've just had a heart attack, or some other really difficult medical reason why they cannot undergo surgery at the time. And those patients can safely be delayed until you've been able to manage those conditions and then offer them surgery. So I know I spoke very broadly, but the summary point is antibiotics as a standalone therapy for now, in my mind, is a temporary treatment and until a more definitive operation can be done. Now, if patients do opt for it, I think you ought to let them know that a third will recur within the first 90 days. And some patients might just say, I want it nonetheless. And, we have patients that are now well-informed. They read the internet before they even show up in the ED. And I think once make this very clear to them, I think they will eventually they'll make up their minds as to which way they want to go. And one last thing I'll throw on that is a treatment option that is very novel, like as of the last 2 years that's starting to catch my attention, is ERAT, and endoscopically treating appendicitis. And so you have an endoscopist going in, retrieving the appendicolith, and cleaning out the appendix from the inside as a definitive treatment. I actually had a patient who had refused surgery from another state. The patient's surgeon reached out to me and say, here's my patient reaching out and saying, I don't want surgery. Is this a patient that you'd be willing to see and talk to? And I had the opportunity to discuss with that patient. And of the many things that we talked about was ERAT. We are not doing it here at Mayo. I think part of the reason they reached out, they thought, well, if there's somebody who is going to be cutting edge around this community, it would be Mayo. And I said, at this point right now, I will not be able to convince any gastroenterologist to buy that idea. The studies that are putting out ERAT, mostly from Asia, and to be more specific, from Japan, and then there's a study from China as an alternative treatment for acute appendicitis. We are not at that point yet, but I thought that was intriguing.
I was going to say that's also not on my order set yet. So,
but if you're listening to this and your patient approaches you and say, "Hey, how about just endoscopy and getting rid of this?" Don't dismiss them as crazy. There's actually something known as ERAT for treating appendicitis. I don't think we're there yet.
Venk, I know one thing that can be hard is to figure out the impact of labs. sometimes people use labs to decide, are they going to get imaging? And then we were also talking about cases where we don't need imaging. How do you use labs in this case?
I don't know that I know the best practice. So for me, I get a white blood cell count. I get labs to look for other potential causes of right-sided abdominal pain. So looking at the bilirubins, lipase, even if it seems distant, because usually there's periumbilical pain to begin with, I include some of those more to exclude other considerations. And then I proceed with imaging, really. And sometimes in kids, actually, I get imaging first, and I prepare by putting topical anesthetics on parts of the skin in case we need labs. But if we get a normal-looking appendix, then I won't follow it. How does that fit with what you do?
I think that sounds pretty similar.
David, what are your thoughts on inflammatory tests? Do you use them? Do you put any weight on this at all?
I think classically is a white count with the left shift. It just helps when it's present. Obviously, I've been in many scenarios with hot raging appendicitis where the white count is stone cold normal. And so when it's there, it's great. When it's not there, I don't think it should make you and I take our foot off the gas. That's really all I'll say. With regards to CRP, because it's such a very promiscuous lab, I struggle with using it, putting a lot of leverage on it. But I know colleagues who probably read European literature know that there's quite a fair amount of emphasis on this. You know, I was in Lisbon in late April, the European Society of Trauma and Emergency Surgery. They had close to half a dozen presentations on appendicitis, and all of them, CRP is very key on their discussions. I say white count. Obviously, in patients who are already in the path of they've perforated, and this is probably one thing I'll add on there. If I see an appendicitis with a white count of approaching 20, I know they've perforated until proven otherwise. That is helpful to me because with or without imaging, I know I'm already standing in front of somebody who has a fairly advanced disease, meaning that's when I put on my fighting gear, and I know this is going to be a fight. And I'll tell the trainee, buckle up. It's not going to be just a sweet appendix. You're going to just staple off and throw in the bag. You're going to actually have to work a little harder here. So white count above or around 20 or higher, they may have already perforated. White count left shift, great. Absence of it, don't be lulled into a false sense of security. CRP, I would not routinely get it. Having said that, I am aware that, around the world, there are folks that depend on it. That's really all I have to say on that. I don't know of any other lab that will really push me in one direction or another. Yeah. And obviously, intraoperatively, I say if you get there and you're perforated, I make an effort to sample some of the fluid in the abdomen to guide antibiotic, for cultures so I can guide antibiotic, as opposed to empiric all the way through. So culture data, intraoperatively very important. Or a patient that has systemic that's raging fever, or you're suspecting other alternative diagnoses. I think culture is pre-op, but otherwise, what I've just mentioned is kind of the way I think through this disease process as far as labs.
David, we're coming close to the end of the interview. One of the areas I struggle the most is when I have a pregnant patient who has pain that could be attributable to appendicitis. Maybe it's a little higher up on the abdomen, etc. I've gotten an ultrasound, and the findings might be equivocal. How do you approach these patients? Would you do it differently? What would you do with that call when I consult?
Very good question, Venk. The pregnant patient is a tough challenge, surgically speaking. And obviously know that the two most common diagnoses in pregnancy, general surgical diagnosis in pregnancy are appendicitis and cholecystitis. And not only makes it harder to diagnose them, you cannot afford to miss the diagnosis because a missed appendicitis diagnosis in pregnancy could spell more difficult challenges than even the risk of exposing them to surgery and anesthesia and things of that nature. The way I approach them is obviously a very thoughtful and careful physical exam. Then imaging becomes a very, very helpful tool to really try to make sure that I'm not taking somebody to the operating room and exposing them unnecessarily to the risk and exposing the fetus to the risk of anesthesia, et cetera. But my approach will be to get an MRI, of the abdomen. And the MRI is fairly sensitive and in many cases also has a fairly high specificity. And some of this also obviously is dependent on gestational age. I think if I was to find myself in a situation where the history is equivocal, the physical exam really is not satisfying, and the MRI is kind of, shall we say, not as conclusive as I wanted, I think knowing that a misdiagnosis carries such significant risk for the pregnant patient, those are the patients that I think I will subject to a diagnostic laparoscopy. Now, I say that, obviously doing laparoscopy in pregnancy at any gestational age is difficult. Perhaps, for most of us, we'll say the second trimester is the best time to do any kind of laparoscopy in a pregnant patient. You avoid the risks, the teratogenic risks of the first trimester, but the uterus in the second trimester is not so big that it becomes a challenge. So if you're going to consider that, those are the patients that I think you ought to be considering. Do I send them to a center where there's somebody who could do this safely? Yes, surgery could be done at any trimester safely. I think the longer the pregnancy goes, the more incumbent it is for you to send that patient to a place where somebody is very comfortable doing those procedures. And here, thankfully, at Mayo, we could do those procedures safely. And so if your workup is not leading anywhere, including an MRI that's inconclusive, I think if the patient's symptoms are not going away and they're consistent, I think you should consider diagnostic laparoscopy.
You've been amazing, and we recognize that you've been incredible on the show. Thank you so much for joining. We have a bunch of listeners who would love to know, do you have any final thoughts or things that we didn't ask you want to share with them?
I think you guys have asked some of the very tough questions that I am still grappling with understanding. I think we touched a little bit about each, every phase and aspect of the disease, from pathophysiology to classical symptoms, and obviously raised, I'm sure the listeners know that not every patient will show up with classical symptoms, and typically the symptoms, you have to really just try to synthesize them and make sense out of them. I think the one topic that I will interject in there, and this is probably more for surgically oriented folks, and that is antibiotics versus surgery. If you are grappling with that again, especially in patients that are older than 50, one thing to lay on their minds, especially, you meet that patient who they read something that said you don't have to take the appendix out. Because there is this cautionary publication from actually more than one organization cautioning us that the incidence of malignancy in appendicitis is kind of on the rise, it has given me pause to just say, if you're older, let's just go and take the appendix out because of that caution. And I just thought I needed to throw that out there because, again, our patients are well informed. They are going to be reading lots of things. I think in an older patient, I will encourage them and say, don't even entertain the thought of antibiotics. I think you just need to have your appendix out. That would be the only thing that I'll add on to that. But I think you guys have done a very good job in asking some of the difficult questions that even I struggle with to this day. And, and obviously I look forward to comments from your listeners, and you guys can direct those to me. I will be more than delighted to engage any of your listeners nationwide and beyond, that have either specific questions or just want to chat. We can share our mutual agreements and also share our mutual concerns as to the areas in this, what sounds like a very simple diagnosis, but areas that are still very challenging that I am grappling with. And then I'm sure that there are people around the world that are still grappling with some of those questions.
Dr. Turay, thank you so much for educating us and all of our listeners today. Thank you for the opportunity to work together here in the emergency department, and seeing your service to our patients is always so inspiring every day. And thank you for the education to our trainees always. I'm looking forward to when I can sneak in the room and watch you teaching. I want to get better. And
well, gentlemen, thank you very much. I really appreciate the privilege to sit with you guys and to share my thoughts on this diagnosis that we mutually struggle with.
This is Venk jumping in afterwards. I did go through, and when I searched PubMed for articles that have in the title C-reactive protein or CRP and appendicitis, and then I subsetted that for systematic reviews and meta-analyses, I only found one, and this is from 2013, the British Journal of Surgery by Dr. Yu et al. and it's titled Systematic Review and Meta-Analysis of the Diagnostic Accuracy of Procalcitonin, C-reactive protein, and white blood cell count for Suspected Acute Appendicitis. In short, this author group, after searching several databases, identified 7 studies that were included. This translated to about 1,011 suspected cases of appendicitis and then 636 confirmed cases of appendicitis. I won't shortchange you the opportunity to read the paper in more depth, but going to the results, they basically found that when pooling all that data, procalcitonin sensitivity was 33%, specificity of 89%. C-reactive protein sensitivity of 57%, specificity of 87%, and white blood cell count sensitivity of 62% with a specificity of 75%. A area under the curve analysis, or ROC curve, found that CRP had the highest accuracy, followed then by white blood cell count, and then eventually by procalcitonin. They did find that procalcitonin was more accurate in diagnosing complicated appendicitis, but still 62% sensitivity and 94% specificity. These were all older studies, and the individual studies that were included were not really high volumes of evidence, or high quality of evidence, or high volumes of patients. So really the yield is weakly valuable in my opinion, but I think it does seem to align with what we were talking about, that these tests might help to add more data points that can push us towards a diagnosis, but I don't think any of us would rule out a diagnosis with normal ones of these. And I personally am not getting a procalcitonin or CRP on patients at all.
The Always On EM podcast, hosted by Alex Finch and Venk Bellamkonda.